Hello, friends. Good evening. I'll be talking briefly on this adaptive support ventilation. As you know, this is a sort of a newer mode which is available on Hamilton ventilators. So, to do this as a part of one of the workshop talks, so I wish to acknowledge Pradeep, my colleague, who helped me develop this content. I gather this has been asked as a question in DRNB. So, for all the DRNB trainees, it may be worthwhile and useful to just go through this. So it is an advanced mode of ventilation, adaptive support. So the question is, why do we need these advanced modes? So the problem, as you would have recognized by now with conventional modes is we do some settings at one point of time, which we believe is appropriate. And as the disease progresses for worse or for betterment, the settings that we may have put at the outset not necessarily may hold good and it may be inappropriate in the situations where the diseases may have progressed. And we have to keep tweaking certain settings. So we need advanced modes precisely for that. And most advanced modes are a closed loop ventilation where there are certain information relayed within the system and the system auto adjusts so that a favorable sort of settings are set for the patient. So in the closed loop ventilation or the advanced mode, so the variables are self-adjusted, and these variables could be cycle or limit or time limited, or it may be pressure control, volume control, flows, cycles, and the time. So all these can be self-adjusted to suit to the patient needs, and it is not limited to single parameter. So otherwise, in conventional modes, we have to set each and every parameters. Here, there is auto adjustments of certain variables to suit to the patient's needs. And this is what is about clever machines, which do auto adjustment of certain variables favorably to help the patient having an enhanced sort of a ventilation or optimal ventilation. So adaptive support ventilation was introduced by Hamilton in 1998. So it is usually present in the Hamilton ventilators only. So the disclaimer is I have not worked with this ventilator, so I have not played with adaptive support ventilation. So in patients who are, as you see, spontaneously breathing, the respiratory system mechanics are analyzed. And if there is a low compliance, if the patient has a low compliance due to ARDS, pneumonia, so the natural effort of the patient to reduce the work of breathing is by doing rapid shallow breathing. So that's a natural sort of a response when a patient has a low compliance system. So he has a pneumonia or he has an ALS. So he will breathe fast and it will be rapid shallow breathing. And this is with an intent to reduce his work of breathing. If patient has high resistance like asthma, COPD, so the way one would reduce the work of breathing is by slow, deep breathing. So he has to prolong his expiratory phase and he has to breathe slowly to reduce the effort of breathing. So these are the compensatory mechanisms. Intuitively, the body has to cope with the increased work of breathing. So his response to reducing the work of breathing in low complex is rapid shallow breathing. In high resistance is slow, deep breathing. So in adaptive support ventilation, you will be seeing this graph, so don't be intimidated by this. So what we basically do is we set a minute ventilation. As you know, minute ventilation is tidal volume into respiratory rate. So we set a minute. You only set a minute ventilation on adaptive support ventilation. And as you know, minute ventilation is dependent on tidal volume and respiratory rate. So this the machine plots this graph and auto adjust the tidal volume, the right optimal tidal volume, and the optimal respiratory rate to attain that set minute ventilation, which is favorable for the patient. How does it set? We will talk about it. Basically, it plots this graph. It takes the highest point, lowest point, and marks the middle point of this graph. And that is taken as an optimal tidal volume and the respiratory rate at which an optimal minute ventilation is provided. So that is the whole science or the quintessence of adaptive support ventilation. So as you see, this graph is plotted, and I will show you in the subsequent slides. You'll understand how this particular central focal point is sort of figured out in adaptive support. So the parameters that we would set in adaptive support ventilation, we set the body weight. So we set the minimum minute ventilation, and we set the PEEP, and we set the trigger. And what machine or the ventilator does, it automatically measures the compliance and resistance of the patient. So it measures the compliance of the lung, it measures the resistance, and it optimizes inspiratory and expiratory ratio. So it optimizes IE ratio, and it avoids auto peak. So it sort of maintains an optimal sort of an IE ratio that a patient needs to avoid auto peak, and it will auto adjust the tidal volume and respiratory rate, which I showed you in the previous graph. So it sets the tidal volume. So the main thing it tweaks is the tidal volume and respiratory rate, because these are the determinants of your minute ventilation. It determines what is the right tidal volume, what is the respiratory rate to achieve that minute ventilation, and it optimizes IE ratio. But FiO2 and PEEP is what we need to set in this patient. So what are the settings that we set? Again, to re-emphasize, so we set the PEEP. PEEP, it doesn't auto adjust the PEEP. You have to set the FiO2, you have to set the PEEP, but you have to measure the height of the patient. So what you have to feed is the height of the patient. So ideal body weight is calculated based on the height, and it calculates the dead space, which is taken as 2.2 ml per kg of the ideal body weight. And you have to put in whether the patient is a male or a female, and you have to set whether you want the percentage minute ventilation you have to set. So for a normal patient, the percentage minute ventilation that you set on the machine is 100%. For asthma, these are all the settings that is recommended to be set for the percentage minute ventilation. For asthma, it needs to be set at 90%. For ARDS, percentage minute ventilation is to be set at 120%. And for others, it needs to be set at 110%. And there is a correction factor. You need to add plus 20% if patient is having fever of more than 101.3 degree. Patient has a fever in ICU, more than 100, you have to add plus 20% to the minute ventilation that you set on the machine. I'll show you on the machine how this is set. You have to add plus 5% if patient is 1,640 feet above sea level. So Bangalore is not above that, so we can set at normal. But if you are at a very high altitudes, more than 1,640, you need to add another 5%. These are all the settings that you need to keep in mind. And I'm sure there will be some sort of a protocol that will be given with the ventilator. So there will be a guideline as to what is. But for all practical reasons, normally you set at 100%. If it is ARDS, 120, which normally we did. If it is a airway issue, set it at less at 90%. So flow trigger is set at 2 liters per minute, and automatic tube compensation in adaptive support ventilation to be kept at 100%. So these are the default sort of a settings that you need to set when you are sort of putting your settings on this ventilator on adaptive support ventilation. So how does it work? So basically there is a feedback that it takes from the patient. As I said, it automatically measures compliance and resistance of the patient. So it takes the feedback of the patient, and it will see what is the tidal volume that patient is generating, right? And then it will compare with the target tidal volume. So because you would have kept the target tidal volume, so it will compare with the target tidal volume that needs to be achieved, and it will send an error signal to the controller within the machine. These are happening within the machine. So there is auto measurements of compliance, PEEP, and this is being relayed, and the observed tidal volume is compared with the target tidal volume, and error signal is sent to the controller. And controller basically what it does is it makes up for the deficit by adjusting the output for the desired breathing so that the target tidal volume is achieved. Basically, the machine is sensing the tidal volume deficit patient is generating and compensate for that. That's all you need to remember. And that machine is automatically doing. Basically, it measures the tidal volume of the patient. If there is a deficit, that deficit is compensated by adjusting maybe the respiratory rate or by other mechanisms, and it attains the target tidal volume so that your goal of minute ventilation that you have set is achieved. So that's what it is doing. Okay, this graph is important. Just pay little attention to this graph. So as you see, the tidal volume is on the y-axis, respiratory rate is in the x. So you set a minute ventilation. Minute ventilation is nothing but tidal volume into respiratory rate. So it needs to match. You have set minute ventilation. The machine has to determine at what tidal volume and what respiratory rate is an optimal way of attaining that minute ventilation. That's all. So what it does, it just draws a curve and it marks different points. And pay attention. If it is So the point A is high tidal volume and low respiratory rate. So the tidal volume is high here, but respiratory rate is low. And it sort of sets that what tidal volume at a low respiratory rate target minute ventilation is achieved. That is point A. Then it goes to point B, where at low tidal volume, here tidal volume is low, and what high respiratory rate, the same target minute ventilation is attained. It averages these two and takes the middle point. That's all it does. So A it marks the B, and C it determines that C is the optimal tidal volume and optimal respiratory rate to attain that tidal target minute. So it's very simple, isn't it? In exam, if they ask, you should just write this graph and say it marks the highest tidal volume and low respiratory rate at which target minute ventilation is attained, and it marks the lowest tidal volume and high respiratory rate at which the target minute ventilation is attained, and middle point it takes as an optimal tidal volume and optimal respiratory rate to attain that same target minute ventilation. That's all this adaptive support ventilation does. And again, figuratively, it shows why the high tidal volume or the tidal volume for that matter overcomes the elastic forces, and the respiratory rate overcomes the resistive forces. That's why we need to have somewhere balance between the elastic forces and resistance forces. That's why you take the middle point, which is optimal respiratory rate and minimal work of breathing. So this is the whole concept of adaptive support. So if you, in exam, if they ask you, just write this graph and say this is how the optimal tidal volume and respiratory rate is set by the machine. I think conceptually you would have understood. And why this is done is to have a balance between overcoming the elastic forces and the resistive forces. So it's a concept of lung protective ventilation, where again re-emphasizing that optimal respiratory rate and optimal tidal volume is taken and a safe window is taken between them to attain the target minute ventilation. Why this is done? This is to avoid all the injuries that happen to the lungs because of the faulty or fallacious ventilatory strategies. This is to avoid ventilator-induced lung injury, avoid barotrauma, avoid dead space ventilation, and avoid autopsy. So all this, whatever that graph it draws and tries to optimize tidal volume and respiratory, helps in mitigating these other injuries that happen to the lung. And again, you can pay little attention to this graph. So only in exam, if there's two graphs, if you write, I think you should get full marks because that's all you need to know in adaptive. So write this graph. So as again, this graph shows tidal volume marked on y-axis and respiratory rate marked in x-axis. So ideally, your target tidal volume should be in between. That's what we thought, right? So if patient is in zone 1, so then your intervention should be optimize the respiratory rate. If the patient is in zone 2, then you don't do any intervention because the tidal volume and respiratory rate is adequate. If patient is in zone 3, so as you see, respiratory rate is high, tidal volume is low. So you need to increase pressure support. If patient is in zone 4, where both are low, then you have to optimize respiratory rate and optimize pressure support. These are the interventions that one has to consider, or the machine keeps in mind when it is optimizing this. So the machine is doing it. You are not optimizing anything. Machine is optimizing respiratory rate if patient is in zone 1. Machine does not do anything if it is in zone 2. If it's in zone 3, where respiratory rate is high and tidal volume is low, machine is sort of maneuvering and trying to attain the tidal volume by increasing pressure. And here there is increase in the pressure support and respiratory rate in zone 4. So these two graphs, if you remember, conceptually you'll understand what adaptive support ventilation is doing. So how do we optimize and control minute ventilation in adaptive support ventilation? So you do an ABG. ABG is normal, don't do anything. Suppose you have high CO2, then you have to increase the minute ventilation, minute volume, percentage minute volume has to be increased. Check respiratory pressure. And if there is low PaCO2, then you have to lower percentage minute volume and again check mean pressure and oxygenation. If there is high respiratory rate, you have to consider increasing again your percentage minute volume and consider sedation. And if it is low oxygen, so obviously you have to increase your PEEP and FI2. So these are the adjustments that you should keep it as a protocol when you are using adaptive support. It's very simple. High CO2, you increase minute volume percentage because you have to increase the flow rates. If it is a low CO2, you have to lower. So very simple. No, high increase, low decrease, High respiratory drive, increase minute volume and sedation. Low oxygen, you can't do anything. You have to increase FiO2 and PEEP. So these are the adjustments in adaptive support ventilation. So the next generation of adaptive support ventilation is this IntelliVent. So right now, whoever is using Hamilton, I'm sure most of you would be using IntelliVent ASVR. So there are additional benefits in this adaptive support, which is intelligent ventilator or intelligent adaptive support, where the targets that are set here is just end tidal CO2 and saturation. And the adaptive, the mode automatically determines the minute ventilation plus PEEP plus FiO2 to achieve this end tidal CO2 and saturation. And this PEEP and FiO2 is adjusted based from the ARDS network table, ARDSnet table that you have for what PEEP, for what FiO2, what PEEP is needed. It derives that from this, and it auto adjusts PEEP, FiO2, and minute ventilation. And there is something called quick wean in IntelliVent, and there is SBT trial, and there is heart lung index. So these are the newer sort of parameters included in IntelliVent. So the heart lung index basically is to determine the hemodynamic effects of the ventilatory settings that you put or the ventilatory parameters that are causing hemodynamic disturbance. And it uses pulse oximeter plethysmogram. It's like a pulse pressure variation or stroke volume variation. It looks at sort of hemodynamic disturbance due to the contributed by the respiratory variation. And obviously, if you have huge swings, then you know there is a lot of hemodynamic disturbance due to the ventilatory settings, and there is some auto adjustment to compensate for the heart lung index. So this is there in intelligent V ASV. So now we'll just move into what are the advantages and disadvantages of adaptive support ventilation. So the advantages is it is versatile and safe. It can be used for actively breathing patients or passively ventilated patients. And as I suggested, adaptive support ventilation prevents all sorts of injury to the lungs like villi, barotrauma, dead space, or auto PEEP. And the most important is since ventilator is doing everything because you just set minute ventilation or you just set end tidal CO2 and saturation, it is auto adjusting lot of different parameters like minute ventilation, PEEP, FiO2, especially in IntelliVent. So less of manipulation and there is reduced duration of mechanical ventilation in some of the studies. So that is the hypothetical advantage. Disadvantage is because the machine is doing everything, you cannot directly tweak because the main purpose of adaptive is it is auto adjusting tidal volume and respiratory. So we have no ability to tweak that. And inspiratory expiratory ratio also it is determining. So these are the three variables which we have no control in tweaking, which otherwise we do for other modes. And we do not know about its benefit in pediatrics. And it is algorithm based ventilation or with low tidal volume and high respiratory rate. So that's the sort of strategy it uses. And the main disadvantage is that this is a patent of Hamilton Medical. So it is only available to be used on this ventilator. And I have not never used this ventilator, so I don't know. So I am not personally have experience on using this adaptive support ventilation. So what about the clinical significance? It is claimed to reduce the work of breathing, improve the synchrony because of that optimal tidal volume and respiratory rate that machine sets to achieve that minute ventilation. And it reduces the time for the liberation from the ventilator or the duration of mechanical ventilation. And there's one study which has shown that adaptive support ventilation in post cardiac surgery has shown early liberation from ventilator and reduce the duration of ventilation. And this may be of interest for our intensivists. Adaptive support ventilation in a small study in pediatrics has shown to significantly reduce the driving pressure when dealing with ARDS. And this is of importance to our intensivists. Adaptive support ventilation as a mode and hypothetically and the scientific plausibility is that it reduces the mechanical power. And I'm sure all intensivists here have learned about mechanical power. If not, you can see my video on mechanical power. Adaptive support ventilation appears favorable to reduce the mechanical power. Why? Because we had not factored in the role of respiratory rate as a cause of additional injury called rheotrauma in ARDS. And that is the aspect that adaptive support ventilation factors in. And if you recall the formula for mechanical power, this is the formula. And your adaptive support ventilation is claimed to, obviously, it will optimize the respiratory rate. and it will lower the pressures. And these are the two ways that it can help in reducing the mechanical power. So if you recall from the earlier talk I would have given on mechanical power, the way we optimize mechanical power is reduce production of CO2 and increase ventilatory efficiency. Reduce production of CO2 is by sedation, analgesia, paralytics. How do we enhance mechanical ventilation? Reduce dead space, end inspiratory pause, prone position, PEEP, and the another aspect is adaptive support ventilation because of best match of tidal volume and respiratory rate. So this is the lessons we had learned when we were discussing about mechanical. So adaptive support ventilation seems to have some favorable effect on reducing the mechanical power. So in lung protective strategy, adaptive supportive ventilation, as we already mentioned, has a better synchrony, and it reduces the barotrauma by reducing the plateau pressure by adjusting the airway pressure to achieve lower tidal volume. So there's one study done by Dye et al. In ARDS where they have compared adaptive support ventilation versus pressure controlled ventilation, and they found mortality wise there was no difference between adaptive support and pressure control. And in animal models, it is shown to reduce the strain on the alveoli. So which means adaptive support ventilation principally and conceptually the way we have understood has this lung protective effect by reducing the strain on the alveoli because of lowering the tidal volume at an optimal respiratory rate, reducing the mechanical power, reducing the risk of barotrauma by reducing the P flat because airway pressures are adjusted to achieve the lower tidal volume. And this is the last slide just to show how this monitor looks. So if you look very carefully, I said you set 100%. So here if you see 100% minute ventilation is set. I said in ARDS you set at 120%. So you have to just tweak to put at 120%. If it is asthma COPD, tweak at 90%. Normal 100%. Others 110%. And you have to add 20% if they have fever more than 101.3. If you might have to add 5% if they are above 1,618 feet above sea level. So you have to set at 100%. And as you see here, FiO2 is set 50, you have set P. And this is the set variables. And these are all the variables that the ventilator. So it has set the tidal volume at 350 as you see. And it sets the rate at whatever optimal rate. And it plots the graph. As you see, it has taken the central point. So in exams, if they ask, I think conceptually, if you write the graph and clearly elucidate as to how it plots and the variables that you set and the advantages of using this as a lung protective means, I think that should suffice to fetch you good marks. So hope it was clear. So you can request all our listeners to attend our signature meet, Global Intensive Care Symposium happening from 18 to 20th October. So request our listeners to submit their valuable work to Journal of Acute Care, which comes out every 3 months. You can visit my website to rehear to this lecture. Thank you. Thank you, Manado.